Hi, and thanks for coming. Would you just go through and tell everyone your name and what clinic that you're at and the role that you play there?
My name is Jennifer Wilson, and I work for St. Alphonsus Medical Group. I am one of 7 population health nurses in our system, and I currently, my primary clinic is 12th Avenue in Napa.
And I am Julie Wolstenhume, and I work for Teton Valley Healthcare. We have 2 clinics, Driggs Clinic and the Victor Clinic, and I am the care coordinator that services both of them.
Great.
My name is Rabin Peterson. I work at Adams County Health Center. It is about 2 hours north of Boise, and I work there as a care manager / care coordinator.
Great. Tammy?
My name is Tammy Cameron, and I am from the Valley Family Healthcare, and we have 7 clinics that cross between Oregon, Idaho, into the Payette, Ontario area, and I am the RN case manager lead.
Perfect. Thank you so much. Thank you for joining us today. If the patient is the center of the PCMH model, then it's probably no surprise that the heartbeat lies within population health management and care coordination. Care coordination assists the patient in transitions of care and accessing the healthcare systems, whereas population health management identifies which patients would benefit from the care coordination services. Efforts for both perspectives work in tandem together to provide efficient and effective healthcare strategies for all patients. Today, we have a group of clinicians from around the state who will provide insight about how patients move within the clinic system and how they access the greater healthcare system in their communities. Thank you so much for joining us today. We really appreciate your time and your effort to come and visit with us today. Can you tell me a little bit about how your clinic defines care coordination?
Well, I discussed this with my team, and we all agree that the continuum is ever-changing, that it really depends on the role in the clinic of the provider, and each particular individual in the clinic has a specific role in care coordination, from the person that answers the phone that's getting that message about patients needing services, from the medical assistant to the RN or nursing coordinator in the clinic. We all play a role in that care coordination, and there's all different pieces to the puzzle. We also agreed that in order for care coordination to work effectively, we all have to have our role clearly defined and also have a clear line of communication between all of the providers and the clinicians in the clinic in order to give the patient what they need. Handoffs in timely fashions is also very important. And avoiding duplicate efforts, we're really big on that because there's a lot of people that are doing similar jobs, and we really want to put the patient at the center and make sure that they are getting timely, appropriate care coordination, but they're not being confused.
Yeah. Julie?
And you know, at Teton Valley Healthcare, our patient-centered efforts are really amplified by the care coordination, is what we feel like. And we are trying to really establish those relationships with our patients. And like Jennifer said, it really starts when they come through the door. We are very rural where I am, and so you know, to have the transitions too for that patient helped to coordinate by someone is really important. It's really helpful for the patient. Also, just coordinating with all of the doctors that we have in our facility, and all of the providers between that and our hospital there also that's connected to our clinic. We feel like it is very important to have that relationship with the patient first off, and watching that grow with the care coordination is super important.
Rabin?
Yes, so when I got to Adams County Health Center, we didn't have a care coordination, care management program. So over the past year, I've been in the works of creating one and coming up with a good definition. Like you mentioned, it's ever-changing. But what we do have is Adams County Health Center defines care coordination as a systemic approach to bridging gaps in our patients' care. We believe when responsibilities are dispersed amongst the care team, patients' burdens are minimized. Our goal is to provide assistance that enables patients to focus on their well-being while being involved in their care.
That is a fantastic definition. Thanks for sharing that with
Appreciate
us.
that, absolutely.
Tammy?
Our clinics have also just started our care management as of January, so we are really new in building what care coordination is. And we decided to accomplish that is to have a mission statement. And so then that gives a definition to everyone so that we all have a kind of a continuity of what that means. And we have included that that is education. That covers a lot of different education. That we are an advocate for the patient, and we hope to empower the patients, the families, the caregivers, so that they can be self-sufficient. And to link these families that we work with our patient and their, whoever their caregivers are, maybe family, with community resources that will help assist the patient and the family in navigating the various systems that are out there, and while doing this, have the highest care possible while maintaining confidentiality and privacy for them.
Is population health management contained within all of your roles, or is that separate from care coordination? Can you give our viewers a little bit of an idea how that works? Because it's different in every single clinic of how that's defined.
In our clinics, we're a fairly large medical group here at St. Alphonsus, so we do support PCMH as our baseline for our clinics, but we do have them participate in population health activities during their regular day. For example, we have daily huddles with our care teams to go over the schedules, the patient needs, making sure we have everything that we need, from pre-visit planning for our chronic disease patients, our diabetics, and also our wellness exams, looking for gaps in care when patients are coming in, making sure that we're providing closure to those and giving those patients what they need. Outreaching patients as well that haven't been seeking care, that are due for wellnesses. That's part of the role that we try to instill from every member, from our front desk staff that are booking appointments to our medical assistants and also the providers. We also have other individuals within the system, our population health nurses, myself, my team, where we do more direct care coordination from hospital transitions, from discharges and ER visits or discharges from rehab to home. We also have the Alliance, which partners with us, and they have a group of care coordinators that do more care management, and they will follow those patients for longer terms of time and provide them with more detailed care and services. And then we also have our BPCI navigators that are located at our Boise and Napa hospitals that also follow certain patients with certain diagnoses that are our higher risk patients. So we all work together to achieve the same goal. So that's kind of our model at St. Al's.
Great, great. Julie, do you have the same model, or?
You know, like I said, we're very rural, and we are not, of course, to the extent that St. Al's has their clinics. But I feel like we really put the personal touch on our patients. You know, I was a nurse at the hospital for many, many years before I was the care coordinator, and I know a lot of my patients I knew before. But we also do things for the community. Yes, I do. I actually. You know, we started a diabetes prevention program this year. We've, you know, I try to get anything going that I feel like will benefit my patients and help them to be more, you know, to be able to follow their care plan and to be more compliant in their medical treatment. And so, you know, we do, and we are striving for our PCM, our NCQA. We're just going through that right now, and so there are so many things that are new, but yet we do feel like we've done them for many years, as far as you know, being patient-centered and following all those good initiatives that the state has put out. But I feel like our coordination program is a little more really personalized in that there's only me.
Right.
With 2 clinics, and I take whoever is referred to me, and I work with. I meet them where they're at, and I go from there. And we do we do a lot of transitions too, and I do also try to keep up with everybody as far as where they've been, because we do a lot of sending out to other facilities that we cannot handle what they need at our facility.
And Rabin, you're out there in the rural areas as
Yes,
well.
yes, I am. The rural areas definitely creates a different picture. But as far as population health management, it's definitely something that our program at Adams County Health Center has evolved into, is focusing on population health. When I first arrived, we really, or my goal was to, do good coordination and whatnot. But the further I got into it and dealing with more chronic conditions, I'm bringing population health into a statistical picture and looking at, what is my care management group's average A1C for the past 3 months, and that's kind of how it's transformed into population health management. So I can look at my community and see, in the past year, their A1C hopefully has dropped, a certain amount of points and whatnot. So that is definitely what our approach has evolved into.
Perfect. Tammy?
I kind of agree with Julie and Rabin that we kind of have a set amount of patient, amount. So we look at St. Al's with their numbers, and then I'd say we're probably at Valley Family below that, and then less. And so with the population health, as they've said, you have to kind of incorporate that into smaller groups, and then you can use that as your whole population, as in diabetics or hypertension. Let me rephrase that, patients with diabetes, or patients that have the hypertension. And then you can segment that out separate than maybe just the person by person care that you give.
Yeah, and that's a great segue into, how do you really define your role in and the activities that you do from day to day? Because we're going to be talking about, workflow for individuals who are looking at setting up a patient-centered model in their own clinics. Can you kind of define your day-to-day activities along those lines a little bit for us?
Yes, it was kind of scary at first when I looked at everything. Along with the charter that we have, it lists all of the aspects the care coordination, care coordinator would be a part of. One of those, we have gone into transitional care management, and so we have a care coordinator that does that specifically, and that has been a huge success in that transition from hospital discharge to a skilled nursing facility or to their home. We also have instigated the chronic care management, where it gives a little more extra time and some reimbursement for other members of the care team that normally is just the fee for service for the provider. We also do screenings for new patients, along with the audit, DAST, GAD-7, PHQ-9, and then we've instigated just in the last few months the social determinants of health, which has been a huge success. And I could go on with many other things aspect, and it just continues on, and we are trying to figure out how best to do it all without just being so segmented in small things.
Perfect, thank you. Anybody else want to jump in?
Yes, absolutely. So activities I do in my role on a day-to-day basis, they really involve a combination of care management and care coordination, and I do believe that there's a difference between the two. And so care management, I really think it's dealing with more internal medicine and chronic conditions, while care coordination, you're dealing with collaborating with other facilities and other specialties that your patients may go to. And so bringing in what our providers want to do with the patients, as well as referring them off to other providers, and then bringing that information that they're looking for full circle back to our clinic is really what I spend a lot of time doing. So whether that's getting medical records from somebody that I'm familiar with that's in my care management program, and making sure they get to their follow-up appointment with our primary care provider, and just the holistic of care, the model of PCMH, and making our facility the medical home for that patient.
Great.
And I would have to agree too, care management, care coordination is, you know, they are two separate things, but they definitely go together, and that's really what I do. I feel like I spend most of my day really communicating with the patients, and in education, I think takes the bulk of my time. Also creating care plans and making sure that the patient understands what their goals are, what we're working on, and that they understand what is, you know, what they need to do to be healthier and to achieve the goals that they want to achieve. Like I say, I try to always meet my patient where they're at, and you know, we work on things that they want to work on that are simple, that the doctor agrees with, and communicating with their providers is a big part too. And then, like I say, just working on things that they will help them be more compliant and help to educate them. So I feel like that is my role. You know, it is always evolving completely. I've done it for 2 years, and it's probably changed tenfold over 2 years. But I feel like we've kind of gotten to a point now that I feel like I feel like I can really help my patients, and I feel like they are helping themselves too. So it's a good spot.
My role is a little bit different because we're a larger system, but I do have a lot of background in care management. I did manage diabetics for about 10 years in my previous role, and I have a certification for diabetes. So, you know, diabetics have a special place in my heart. Also did inpatient case management as well. So I kind of have a good idea about the resources in the community from that role transitioning into this role. Most of my day is spent doing transitions of care. We have we're a pretty large medical group in general, so I do all those outreach calls, making sure that the patients understand their discharge instructions. Med review is huge. It's a very difficult thing for most patients to follow their medications, and then when they're going in and out of facilities, things are changed. A lot of education for our patients. But then also, because we don't have social workers in the clinics, I often put on that hat as well. So if providers need more resources for patients, they just don't know what to do, they'll refer them to me. I'll either meet them in the clinic, call them, find out what they need, and I'll get them the resources they need. But I can also reach out to our partners with St. Al's, our Alliance partners. We have a social worker within the Alliance that can help with directing needs for patients. But we also have our BPCI navigators in the hospitals that also will help coordinate care for patients, and they can take it up a notch that I'm not able to do due to time constraints in the clinic. That's the bulk of my role. A lot of education. I do do some one-to-one diabetic education in the clinic as well with my diabetic background. Working with other providers, so I do a lot of records, getting a lot of records. So as you know, records, sometimes we don't know the patients are there. We find out that they are here, they're there. So a large part of my role is helping the providers obtain all the records that they need so they can be able to make sure that they're able to put together that plan of care for the patient. Sometimes I'll follow patients short term if there's more care management type of needs, but that's the bulk of our role since we're such a larger system, and we have a lot of people doing the same type of work, so we try to make sure that we're, like I said before, we're not duplicating efforts, because we really want to maintain that patient-centered focus and make sure that we're doing due diligence and getting the patient what they need.
Sure. Before we move on to the next question, let's talk about transitions of care a little bit. Make sure that we define it, because it may look different, just like care coordination looks different in every single clinic. So transitions of care maybe, for me, would be moving from one provider to the next, or one entity to the next, from the primary care to a specialist, or to the hospital, or ED, or whatever service, but it may look like building to building. Is it also some things that happen within your clinic that you guys consider coordination or transitions of care? What does that look like for you guys?
For St. Al's, most of the staff would say that it's transitioning from a higher level of care back to home whether that be an inpatient stay, an emergency stay, a rehab stay, or other institution type of stay, transitioning them to home. Sometimes it does include transitioning that patient from home to an assisted living, or transitioning them to a higher level of care because they're no longer able to maintain their needs at home. It also will involve transitioning providers. We have a lot of patients that are coming from other places, then they're moving from provider to provider, and then the specialties as well. So I would agree that those all would meet a transitions definition for me.
You know, I think, as I said, we are connected to a hospital also, and we try to watch out for people who are using the emergency room as their primary care. And so we try to pick up on that and try to transition them into primary care so they're not using that. But we also check the census once a week. That's one of my jobs, is to check the census and make sure that none of my patients, or if they've been in there, that they are receiving a phone call and making sure that they get back to their primary care within 3 days. And we also have someone else checking just the regulars, you know, for everyone else, and making sure that they are getting back in to see their appropriate doctor for their follow-up. And so that we just don't want people slipping through the cracks.
Right.
And so that's kind of, as far as transitions, yes.
Yeah, transitional care. Me and Tammy have actually just briefly talked about this. A couple weeks ago, she sent me an email and wondering if I was doing transitional care at my clinic. And we deal with a lot of internal and external referrals from the providers, sending them to specialists. And then we also have physical therapists in our clinic, and we have an optometrist and dental department, and a pharmacy. So I do deal with a lot of transition of care within our clinic, but then also outside of our clinic as well. And outside of our clinic, it looks a lot like, you know, making sure the referral gets through, making sure the patient has transportation to that appointment, making sure that the information that was obtained at that appointment comes back to our clinic and gets to the primary care provider, and then that patient has a follow-up appointment with their care provider to talk about the results from their appointment with their specialist. And so there's a lot of things that are similar to care management or coordination that's in transition of care.
Sure. Thank you. Tammy?
Yes, also, it goes back to relativity of numbers.
Right.
And so, you know, everything that has been said is exactly with Valley Family. You have the external, and with us, we have all 5 of the hospital systems that we need to gather that information from. So that has become a challenge, and we love challenges. And then those transitions from inpatient or observation to, you know, skilled nursing, as I had said before, that's like that external that we can help with. But internally, what is exciting is that we have behavioral health, we have a dietitian, and so now those can be those warm handoffs from when the patient is seeing the provider. He can come out and actually, he or she can come out and find someone to actually transition them to another department, as you could say, but they're face-to-face, and be able to address those problems with them right then. So that has been a huge advantage, and patients like that.
Yeah, and they're in the same building too,
Yes.
so it makes those transitions much easier.
Yes.
Especially where transportation could be a problem.
Definitely.
Or, you know, you're far away from other services. I have been to the St. Al's Clinic and to the Adams County Clinic personally, and so it does look very different as to how far away you have to travel for other services that are outside of your brick and mortar building. So, thank you. What kinds of resources and tools are you using to keep track of all of this stuff? That's got to be crazy busy. EHRs aren't always, you know, the best ways to track that, and so we've got add-ons and all kinds of workarounds that probably happen. Can you share with us the things that you're able to accomplish and the tools that you use?
So for St. Alphonsus, we have an internal report. We call it our BART list. And that list is populated every day for all of our inpatient admissions and discharges, ER visits. It's got every type of visit that was in the hospital. So the problem with that is it's only our patients. It's only patients that were at the Boise, Napa, or Ontario hospital. So we also do have to coordinate care with the community hospital in Napa. Currently, the process for that is they send what's called a CCD, which is a continuing care document, and that's actually routed directly into our EHR. And I get those every day, so I can go through those to look to see what our patients were there for and if they need follow-up for that. IDHD is also a huge resource for us, especially for St. Luke's. Not everybody has access to St. Luke's records. I do, but it's very limited. So IDHD is something even all of our medical assistants are trained. They all have access to IDHD. So for any primary health, St. Al's, or St. Luke's patients, we can go in there and we can access records really quickly. For myself, for tracking my patients, once I've pulled all the resources, I use the EHR to help me coordinate timely follow-up for when I'm following up with the patients. I always follow up with the patients once they've seen the primary care provider to make sure that they didn't have questions after their visit. So I have my own organization through the EHR and spreadsheets and things like that. But our biggest, like I said, our biggest source is going to come from IDHD. Faxing sometimes is not as reliable. Phone calls come a lot to the clinic from other facilities saying your patient was seen here, we need to get him in for follow-up. So that again goes back to communication. Our front desk staff is the first in line. They will message the person that's doing the care coordination or the transitions work, who's usually myself, and I will follow up, make sure I get the records. And so it depends. Everybody has a role in the transition, so if they call and they don't message me, then that's a miss. You know, even though they have an appointment. So we really try to make sure that everybody is working and doing their specific jobs to make sure that we're again, getting the patient in and getting them what they need.
Perfect.
Yeah. We are not part of IDHC yet, but we're looking forward to that. I think that will make life a lot easier. But, you know, we do have access to the surrounding hospitals, at least two that we can get medical records from. I do depend on my patients a lot to tell me what's going on, so I feel like I am, you know, in contact with them enough that, or you hear through maybe their provider or something will show up in their chart that you know that something's going on. But that is a hard part of it. We do use Dulcian, which is an add-on to Athena, to track time and patients, and that does help my job quite a bit. So, but it is kind of hard to find things that are really valuable, you know, worth the money to purchase that help. But that seems to be helping me anyway.
Yes, tools and resources. I use, you know, the obvious resources in our community, whether it's patient assistance programs for medication, nutrition, transportation, home health, and hospice. Those are definitely vital in our program. But the most important tool that I've found over the past year is documentation and creating my own spreadsheets. When there's, you know, you're managing care for a patient, and if anything gets left out, or, you know, just a small conversation you might have with that person, and you don't document the EHR, it will come around and come up missing, and it'll be obvious, you know, and create a gap in the care. And my job is to bridge the gaps in the care. So I've learned to be very punctual with my documentation and specific as far as what we talk about and my goal. So yes, the documentation and spreadsheets have been very vital in our program.
And it's interesting, even with data of any sort, that you really don't know what you're going to need until later, and you go looking for it.
Exactly.
Very true.
And it is hard to recreate, isn't it? Tammy, how about you?
That was one of my first questions to others. I reached out saying, how do you keep track of your panel of patients that you are following without it becoming huge and unmanageable? I also ended up with a spreadsheet that I look at some days and wonder about, but it does assist me in being prepared before a patient may be seeing a specialist or their PCP, so that I can make sure that everything is in order as far as results of labs that may or may not have come in, specialist reports. And so with that tracking tool, it is beneficial for the patient's care, and also then makes efficient provider time, so that you're not having to follow afterwards in the remains. And that has happened, so that has been most beneficial. Our EHR is able to produce reports that also helps to be able to just generate a quick list of when the next appointment is for each care coordinator, and so that they are aware and be able to get that instead of last minute saying, oh, I see my patient is coming in today. And so it's all in preparedness. One of the best resources is our care team and the patient's families. They are all the team, and when we use each team member, that's the most reliable and best resource that we've found.
And a lot of times in the smaller communities, it's probably easier to track some of those gaps in care than in the urban areas, because although Susie might not be telling you everything, Edwina came in after her and filled you in, right? So that might be a little easier.
Yeah, definitely.
How do your activities contribute to this notion of the triple aim, or even the quadruple aim, adding back in that provider satisfaction? Do you notice that there are shifts in paradigm in your clinics because of the way that care coordination and services are delivered to the patients?
The biggest one I get is, wow, how did you know I was in the hospital? I'm so glad you called. I think it increases the patient's confidence in their provider, number one, that you care, which builds trust and rapport with the patient, which builds compliance with the patient with their plan of care if they have a relationship with their provider. A relationship's the key. If they don't trust us, we're not going to be able to help them with their care. They're not going to trust what we say. So that's the biggest thing. So we felt it's all about that relationship with the patient, which hopefully, if the patient has trust in the provider, that they'll be more compliant with their plan of care, be more compliant with their disease management, which will in turn lower their readmission rate, them utilizing more healthcare services, decreasing the cost. Also, by us boosting that quality of care, we increase patient satisfaction. So we felt that the care coordination is really the key, because we have to have that relationship with the patient in order to meet the triple aim.
And do you feel like it's increasing provider satisfaction along those lines as well?
Yes, I do, and especially the follow-up calls as well. You know, patients are, they're surprised. Oh, well, thank you for calling. Yeah, actually, I did have a problem. And a lot of times patients won't call the provider. They're embarrassed because they didn't understand what the provider's instructions were, but then when a nurse calls behind that, they actually open up to us and tell us, well, you know, I really didn't understand what doctor said. And so I think it's just wrapping up that care and providing the patient with extra resources, because they don't always hear everything and don't want to ask the question because they feel like they're pressed for time too. So I see it all the time. Patients will come in and ask to see me, because I do a lot of my work as telephonic. They'll ask to see me, and they're so appreciative of everything we've done for them. So yes, I've seen it makes a difference, because people will tell me. So it's really rewarding, actually.
Great.
Yeah. I see myself as an extension of our providers that I work with, and like she said, it's the patients really do appreciate it. A lot of times, you know, after a visit, I'll call to help them titrate a lot of blood pressure medicine, a lot of diabetes medication. So I'm calling them for a period of time, maybe every other day or every third day, and or just, you know, after they've gotten a new medication and you call to see how it's going, and they'll say, you know, it was $800. I can't afford that. I couldn't buy it. But they won't call back to tell you that. It'll just be another 6 months before they feel like they need to come to the doctor again, and then the doctor finds out that they didn't start the medication. So I feel like we're bridging that gap quite a bit, because then, you know, I can help find ways that maybe we can, get into a program where they can get the medication, or we look for another alternative if that's the case through the physician. So, I just feel like it closes the loop, and the patients really are grateful. They really are hesitant sometimes to call, depending on the patient, and I feel like that's very important. And the doctors really do appreciate the follow-up, so that they know what's going on with the patient, and that they can, discuss with me how I feel about where I know the patient. They know the patient. I probably spend more time maybe with the patient because I call them more often. And, you decide on a personnel, you think, well, I think they would handle this, and they,
Yeah.
it's a little more personalized. And
Sure.
yeah.
So my understanding of the triple aim approach, I researched it. It's better care, or better health, better care, and lower cost, correct? So the better care definitely starts with the provider, the appointment they have with the provider, and the plan of care that the provider establishes, and then me as the care manager to follow up with that plan of care and create my own plan of care along the way to aid in the provider's plan of care. And then that results in better health for the patient, and then me also providing the patient with education and resources they may need to be able to better care for themselves. I'm really adamant on independence and taking care, the patient taking care of themselves. So that's better care and better health. As far as lower costs, that's something I've definitely struggled with. I believe that in medical you pay for what you get, unfortunately, as of now. So I'm still working on figuring out ways to lower costs for patients, but I do think it mostly comes from keeping them out of the hospital, and that's where the lower cost comes from.
I'm glad Julie brought up that example, because then it triggered how my activity, this was an amazing case that a homeless man, of course he has uncontrolled diabetes, but he developed an ulcer on his foot, ended up seeing the wound clinic, ended up seeing the podiatrist, and it just didn't get better because there just isn't that care, the food, everything, all of those social determinants that affect him. And so it was like, well, the doctor is going to do surgery tomorrow on him. I said, well, where's he going to live? Who's going to change the bandages? And he does have Oregon Medicaid, and I just called through a process of many calls, who can help in this situation? He can't have outpatient partial amputation of his foot and go back out on the street. All along the way, it's like, there's not going to be any coverage for this, but you can try. I said, well, yeah, let's try. Received the call, miracle. It was a miracle that they did authorize to have him inpatient rehab for up to 20 nights.
Wow.
Of course, at the end of that, I'm not sure what's going to happen. Most likely he'll be out on the street, but that wound will have some time to heal with proper nutrition and some physical therapy to help. Otherwise, the activity of a care coordinator not being there, I don't know who would have done that, because nobody thought it was possible. So that's one example of meeting that aim of all of that, because the next step, put him back out on the street without any rehab, he probably would have had to have an amputation of what, and keep going up, how far, where does that go? And so to me, that's the perfect example of that triple aim. And also the provider was very happy to know that, because it was on his mind of, what's this patient going to do after I take part of his foot off?
Yeah, that's a great example, both of costs and patient care. Yeah. What do you think is the value of care coordination or population health management in the patient-centered medical home transformation process? Go ahead, Julie.
I think it's key. I mean, of course, you're talking to the care coordinator. But I think it's key. I mean, I think it is definitely a team. I mean, I feel like we really have a cohesive team where I work, but, I feel like I work with everybody, and everybody works with everybody, but I feel like care coordination really is a super important part of that. in that I feel like the patient, you know, and I have lots to do with even patients that are not my patients that are on my list that I call, you know, that they know that somebody will be in touch with them, and they know that they can always call me and call the clinic and get an answer and get back to them in a good period of time. But I think it's very important to have the care coordinator as part of their transformation into patient-centeredness. So,
Yeah.
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 We feel that care coordination is an absolute pillar to being to transformation, to be a patient medical centered home. Because without that care coordination, you cannot be patient centered. It just won't happen. So without care coordination, there's no way that you can maintain that population centered model and care for the patient at the center. So it's absolutely a pillar. Without it, I don't think you'd be successful.
Tammy, Raven?
Yeah, with the patient-centered medical home framework, just funneling in all the information that I can to the primary care provider, just to give them the opportunity to provide the best care possible to the patient, is really my goal. So I work really close with the care providers, as well as the patient, and also with our, you know, records team and whatnot, just to gather all that information and present it to the provider. We have a lot of cases of providers, specialists wanting our providers to prescribe what they've prescribed. So if they go to a cardiologist appointment and they have changed their Coumadin to 5 milligrams twice a day instead of one time a day, and I miss that and I don't bring that information back to our care provider, and then the patient calls the cardiologist and asks for a refill and they say no, you're going to have to go to your primary care provider, and then they do, and the primary care provider has nothing to lean on as far as, you know, changing that medication dosage. So it's really important for me to make sure everything comes whole back to our clinic for the provider and the patient. Is really my job to keep those two happy.
Those are good people to keep
Yeah.
happy. What I have found with the transformation, because I have been employed with Valley Family that has been in the PCMH program since the initiation of it, and to watch that shift of how we are caring for the patient and getting to this point where care coordinators are a part of that team in our instance, you can see the change. To me, you were referring to like the pillars. I refer to everything to an analogy is how I can say it. Because those pillars, with care coordinators being those, is what keeps that structure from having cracks. And that's where our patients have always fallen through that need that help, is in cracks. It's like whether it's financial, you know, through their medicine, prescriptions, there's just all these cracks that they're in, and then we are finding those people in those cracks and be able to get them up and have a pillar there to keep that a good foundation of that primary medical home, so patient-centered. And that's my analogy of our foundation.
Yeah, that's perfect. That's great. And so many times, some of the cracks are systemic as much as they are just about the patient's responsibility. I notice that some of the patients that I speak with on the phone, just in getting their perspectives on, you know, what transformation is about and that kind of thing, you hear their stories that they're doing everything that they possibly can in these situations, but then there's this systemic problem, and so you guys being able to fill in those gaps is really crucial for them. If you were to look back and think about the information that you know now and you wish you would have known then, is there a golden truth that you could share with our viewers today? Tammy?
But with Valley Family, as I said, being from the initiation of the PCMH, what I can see, if we were to even go back to the beginning, there was a lot of leadership and a lot of foundation that was put in. But right now, I think if you talk to the employees that have been there through the 4 years, or three-ish almost, there's still some that don't have that concept of the transformation. And so that's what I wish, to go back. I don't know what would be different, but somehow to have more education for all the employees, nursing staff, referral desk, drug assistance program, to have everyone have the vision instead of just those that are making the vision. So that's one thing that I would have liked to have seen. That the good part about it is that we have that foundation, and it is in the works, and it is working, and so we can build upon it. One of my goals as I've gone through this is that I would love to have every patient that comes in to see their PCP know what they are doing there. Most of the time as a nurse, you bring a patient in, you triage them. What are you here today for your appointment? I don't know, I was just told to come in. And to me, that is not having an engaged patient in their own
Right.
health care. And so when we end up with one day having all the patients say, oh, I'm here for my diabetes check, or I am here for my hypertension check, then I'll know that we have hit the triple aim of having that whole loop and being able to have it transformed patient care.
Great.
I started, and I didn't even know what a chronic care coordinator was, so I kind of felt like I was a little alone in this, and I had to do a lot of research and find out exactly what I was supposed to do. But I feel like I've got so many different opinions. I had some of our PCMH coaches telling me that I could have 250 patients, and then I soon realized that was unrealistic. And so I think it would have been really nice to have a mentor, and I try to do that for new chronic care coordinators on my end of the state. I have people call me every once in a while and just kind of ask me how I do things, because I kind of made it up as I went.
Yeah.
But I think you just need to learn to relax and put your patient first would be the takeaway. I mean, you still have to jump through Medicare hoops and hoops for your facility, of course, to make things work. But I think you just put them first and look at their needs, and things will go well, and just everything that they said too.
Jennifer?
I kind of have a different outlook because I came from another state before coming here to Idaho, and I worked for a very large national medical group, and we had all the tools we needed to be successful with population health management. So my big thing was knowing that, going back in time. It was like going back in time for me when I came to Idaho, because we're a little behind, most other states. But is having those tools throughout the journey to help you be able to do the job you need to do. And also that change aspect, where you're always going to have that 1/3 rule. 1/3 are going to buy in, 1/3 are going to be, okay, I'm not too sure, and the other third are just not going to move. That you have to just know that it's going to be a constant revolving change, a constant circle. You're going to get resistance, you're going to have to modify, and you're going to get that resistance, but you just have to keep pushing through in order for that change to happen. So, and lots of time. You've got to give yourself lots of time to make the change. None of this will happen overnight. You've just got to make sure that you give yourself time. So time is the one thing that everybody wished they had more of, right?
Yeah, patients included, right? To be able to reverse some of their situations that they're in, and be able to be more effective and efficient for themselves as well. That's great. Well, thank you so much for your time today. We really appreciate you being here and sharing your thoughts and ideas with our viewers today.